right, so the last thing we need to talk about in the heart here is that we're going to talk about something that's a little bit more theoretical, but we're going to be looking at what is kind of considered to be the mechanical properties of the heart. So this is looking at really, it's not something that's easy to measure, but it is a good way to kind of understand what the heart is doing and how that can influence blood pressure. But we're going to be looking at the amount of blood that the heart can pump out in a particular beat or in a particular period of time, and talk about things that can influence that. And one of the things that we're going to see is when it comes to blood pressure, one of the quickest ways to either bring up or drop the blood pressure is to really influence the output of the heart. Simple plumbing kind of dictates that water pressure is going to be higher if you have more water in the pipes. And that's basically what output of the heart is doing. So some of these things are pretty straightforward. I think everybody's pretty obvious what heart rate is. So heart rate is just how many beats in a minute that the heart does. We've also talked a little bit about how most of the blood flows passively into the ventricles, and then you have the aortic go into systole and push the rest of the blood down into the ventricle. And then we have that ventricle contract, and the amount of blood that it pumps out in that single beat is what we refer to as a stroke volume. So an easy and I think kind of obvious way to get an idea about how much blood the heart is pumping out in a particular period of time, and they did this, but it makes sense even just looking at this slide, is if you wanted to kind of know how much in a minute, we know what the heart rate is, and if we know how much is pumped out with each beat, if we multiply those two things together, that can give us how much blood is pumped out of a particular ventricle in a minute. So if we do heart rate times stroke volume, that is going to give us cardiac output. Cardiac output is the blood pumped out of each ventricle or a ventricle in 1 minute. It is very simply the product of stroke volume times heart rate. So it kind of shows you here an example of 70 mils per beat, or a stroke volume of 70 milliliters times 75 beats in a minute. That is 5.25 liters of blood per minute. Again, anything that's going to influence the stroke volume or influence the heart rate would obviously influence cardiac output as well. Again, that cardiac output, we're going to see that this is very much tailored to level of what you're doing. Generally, the smaller the heart, the smaller the stroke volume, which means to have a particular level of output, the resting heart rate is going to be higher. This is part of the reason that women generally have higher heart rates than men, and children and newborns generally usually have higher heart rates than adults. It just takes more beats to pump out a certain amount of blood. Larger the heart, the larger the stroke volume. The other thing we can see is with endurance training, you can get increased strength as well as volume of this heart, and that can allow you to support very, very low heart rates to support a resting cardiac output. Lance Armstrong is an example that they gave kind of in the book here, but a resting heart rate of 33 beats a minute. Myself, I have a resting heart rate somewhere around 48 to 50 beats a minute, which is lower than that kind of average 60 beats a minute for the low end. So again, with you doing more of this, you get a larger volume and more strength. Heart can do more with each beat, larger stroke volume, so you don't need as many beats to maintain a particular cardiac output. What is referred to as the cardiac reserve, this is really how much more cardiac output you can do above that rest level. Again, if you're doing more with each beat, it means you're going to have more in reserve. But this is really your cardiac max is really whatever your stroke volume is times your max heart rate. If your resting heart rate is 50 and your max heart rate is 200, that means you have 150 beats times whatever that stroke volume is. You can get this big increase in output of the heart, and that amount that you can increase that over rest is that cardiac reserve. The other thing we'll see is with intensity and other things like that, you will also see increases in stroke volume to really going up quite a bit. We're going to see overall this heart rate reserve in most healthy non-athlete type of people. You can see 3 to 4 fold increases in cardiac output. 7 to 8 fold in really highly trained athletes. Obviously, if you're having heart condition or something else like that, you may have very little reserve, and it really limits how much exercise you can do or how active you can be based on the fact that you don't have this reserve very much above rest level. what we're going to see is, again, anything that can influence either heart rate or stroke volume is going to influence cardiac output. And we can talk a lot about different things that influence cardiac output. And again, the thing to keep in mind with all this is anything that influences cardiac output is also an influencer of blood pressure. So all the stuff we're going to talk about here, if we go on, when we go on to the next chapter here and we talk about blood pressure, it is going to be going back to all these things as well. These chronotropic agents I'm going to talk about in just a second, these influence blood pressure. So a chronotropic agent, if you go with the prefix chrono, that means time. So this is really things that are going to influence heart rate or change how quickly the heart beats. So it's messing kind of with the timing of the heart rate. Chronotropic agents are going to be things that influence those nodal cells, those SA node and that AV node. Again, depending on which way we're going, these may increase that heart rate, they may decrease that heart rate, and that's where we get into these ideas of positive versus negative chronotropic agents. A positive chronotropic agent is going to be any type of hormone, neurotransmitter, or anything else like that that is going to increase heart rate. So sympathetic stimulation of the heart is going to be a positive chronotropic agent. Things like epinephrine, norepinephrine released by the adrenal glands is going to be a positive chronotropic agent. Obviously, can be stuff that could be injected into you that are drugs and other stuff like that are also positive chronotropic agents, but we're kind of keeping it to normal physiology. So the sympathetic stimulation of the heart and release of epinephrine and norepinephrine that binds to those beta-1 adrenergic receptors that we talked about is going to increase the leaking of those sodium ions and therefore get calcium into the nodal cells quicker. They reach threshold more quickly, and this increases that firing rate. That is an idea of a positive chronotropic agent. Beta blockers, which block that beta-1 receptor, would be an example of a negative chronotropic agent that could inhibit this. Thyroid hormones increase the number of beta-1 adrenergic receptors, make you more sensitive. Those are also positive chronotropic agents. Caffeine is kind of a neuromodulator. It's going to help increase second messaging signaling on this and then get increases in heart rate. Things like nicotine, similar idea, stimulates norepinephrine release, increases the heart rate. And something a little bit more illicit, cocaine actually is a norepinephrine reuptake inhibitor, means more epinephrine stays present, and that leads to this really fast heart rate. Obviously, if you get too much of that in the system, it can lead to a heart rate that is beating too fast, can lead to a heart attack. Negative chronotropic agents, on the other hand, are going to be anything that is going to decrease heart rate. So this, first off, is parasympathetic innervation, releasing that acetylcholine and binding to those muscarinic receptors. It leads to hyperpolarization by opening up more potassium channels. This takes it longer for your SA node to reach threshold and is therefore going to slow down the heart rate. As I mentioned, any drug that blocks that positive chronotropic signaling pathway, like a beta blocker, is also going to be a negative chronotropic agent. Beta blockers, like I said, bind up that beta-1 receptor and inhibit the effects of epinephrine and norepinephrine. One of the first line drugs that deal with blood pressure. We're going to see there's also, if we're going to think about things that influence output of the heart, we talked about the chronotropic agents. Those are all focused on heart rate. But we know it's the combination of heart rate times stroke volume. So the other thing that we can see is anything that is going to influence stroke volume is also going to influence cardiac output, and we could have kind of positive and negative influences to stroke volume. One of the things that is greatly going to influence stroke volume is just the amount of blood coming back to the heart. The heart is a one-way kind of pathway here due to the fact that there's valves in there limiting the backwards flow of blood through there. And what this really means is if you get more blood through increased venous return back to the heart, more blood into the heart has to mean more blood out of the heart. So if you're being more active, moving your arms more, pumping more blood into your heart, you're going to stretch that heart muscle a little bit more before it contracts. This idea is called preload. It's kind of the idea if you were to blow up a balloon, if you put more air in the balloon, you stretch it more, it can more forcefully, you're going to get more air out of the balloon. So kind of the same idea here. We increase that end diastolic volume, which means we're going to pump more blood out because we can't send it the other way because there's valves stopping that backwards flow. So preload is just this stretching. We get a little bit more blood into the ventricle. It stretches that ventricle a little bit more. When it contracts, it's going to push more of that blood out because, again, that AV valve's not going to let it go back to the atria. And there is somebody that came up with a law on this one, the Frank-Starling law, but it's a very simple idea that more blood into the heart means more blood out of the heart. That's all this really says. We get more overlap, a better stretching of the heart. It gets the most forceful contractions, and this is going to increase stroke volume. But more venous return to the heart or more blood into the heart means more blood out of the heart. So simple thing to think about with venous return, more in has to equal more out. Again, less stretch if there's less volume, less overlap, less forceful contractions, lower stroke volume. So decreased venous return means decreased stroke volume, decreased cardiac output. And again, this is going to be really due to that venous pressure, which again, a lot of times is going to be due to you moving more. We have one-way valves in the veins that we'll see in the next chapter, but the more you contract your muscles, generally, the more blood you're going to force back to your heart. Same thing with increased breathing rates are going to bring more blood back to that heart. And again, during exercise, venous return, because you're doing that much moving, you can really double your venous return. And this is also part of the reason when I was talking about resting heart rates, you can support max heart rates of up near 200 beats a minute if you're being active. But really, if you're not being active, the venous return at rest is not enough to support those high heart rates. And that supraventricular tachycardia, if you start getting beats above about 140 beats a minute at rest, you're at risk of a heart attack for the very simple reason you're not getting enough venous return to support that high heart rate. And mechanically, you're basically going to run the pump dry, which can lead to a heart attack. Again, if we slow down the heart rate, we can allow more time. But again, with exercise, we can push more back due to that muscle pumping effect. Things can also negatively influence this. So if you have a hemorrhage, some type of blood loss, you're going to have decreased venous return. If we start getting heart rates too high, like with the supraventricular tachycardia, especially if you don't have the strong venous return pumping it into the heart, you can, as heart rates get higher, there's less time for it to fill. So, and again, anything that decreases stroke volume is going to decrease our cardiac output. The other thing is they need to be balanced. So the amount going into each side needs to be similar, and the venous return getting back to both sides of the heart has to be about the same. Another thing that can influence this is back pressure against the heart. So we've talked about stretching it on the way in, but if you have more pressure against those exit valves of the heart, against the pulmonary valve, against the aortic valve, due to, let's say, higher blood pressure, it's going to take more force to open up that. And I always use the example, if you're in a classroom and you're trying to get out the door really quick, if the door swings open and stays open easy, more people can get out it faster. If you have somebody on the other side of the door pushing the door closed, it's going to be much more difficult to get people out of that room at the same rate. Afterload is kind of the same idea. If you have increased pressure against that exit valve, it takes more pressure to get the door open, and once that pressure starts to drop, that door is going to slam shut sooner. What this really means is that increased resistance means less blood is going to get out with each beat. Atherosclerosis can also contribute to this by giving you less space to push this blood out to and have increased resistance, which is going to lead to more blood staying in the heart, a greater end-systolic volume, and less blood having left the heart. Decreased stroke volume, decreased cardiac output can be a problem. But again, it's this back pressure that afterload on the left side of the heart is generally much greater than the right. This is something over long periods of time is what we refer to as congestive heart failure, where if you have too much afterload, too much pressure on this one, the heart has to keep getting stronger, so it keeps getting thicker in the walls, but without getting any increases in volume. If the heart continues to thicken, sooner or later, and if you've ever known somebody that's lifted a ton of weights, if you get too much mass, you lose flexibility, and that's what tends to happen with the heart. You get a buildup of this muscle thickness in the wall without increases in volume like you do with endurance exercise, and it becomes this kind of positive feedback cycle where the heart gets thicker to try to pump more blood out, but it decreases the volume, and over time that leads to heart failure, that congestive heart failure. And again, it's a lot of times a result of increased afterload. I mean, this is a long-term problem that takes about 20 years to get congestive heart failure, can be a leaky valve, could also cause this problem. The other thing we see is there's actually hormones and other things like that that can influence how hard the heart contracts. So ionotropic agents are going to be these types of hormones or neurotransmitters that are going to influence how strongly the heart contracts. So this term that about how strong the heart contracts is contractility. So increased contractility is going to be in a more forceful contraction. It's generally due to more available calcium in the sarcoplasm. We get better cross-bridge formation. The heart contracts more strongly. Increased contractility means more blood pumped out. Decreased contractility means less blood pumped out. So not surprisingly, we can have positive ionotropic agents. These are going to increase the levels of calcium, increase cross-bridge formation. Norepinephrine, thyroid hormone are both things that the body releases that are going to increase the amount of calcium available. So norepinephrine from sympathetic, thyroid hormone increases the number of receptors for epinephrine. These speed up that heart rate at the SA node and AV node, but they also, in a lot of the rest of the heart, are going to increase the strength by which that heart contracts by allowing more calcium ions into these cells. There's also the drug digitalis that you can give to somebody that is having issues with cardiac output, which will increase the strength by which that heart is beating. That's another positive chronotropic agent. Negative chronotropic agents obviously are going to do the opposite thing here. These are going to block calcium. So a lot of these ones are calcium channel blocking drugs. So if you're getting extremely high blood pressure, this is kind of the last line type of drugs. You're generally going to do beta blockers, and we'll talk about ACE inhibitors in the next chapter. But these calcium channel blockers can be given to decrease cardiac output and drop blood pressure. Again, there's a little bit more side effect with these ones. There's a little bit more going on there. But if you get decreased calcium in here, you get less contractility. You don't pump out as much with each beat. That the negative ionotropic agent will drop cardiac output. And again, that's if everything else remains the same. And again, this increased contractility, that intrinsic strength by which the heart beats, the more higher the contractility, really the more output the heart is going to have. The lower the contractility, the less output we're going to have. Again, all other things remaining equal. And the thing to remember on like a lot of this cardiac output stuff, unless I say something different, and we'll say the same thing with blood pressure as well. Unless I say something different, if I say this changes, even if I don't state it on a particular question, always realize that assuming everything else remains the same, if this changes, what happens? Don't start trying to read in more to the question that's there. So again, anytime I'm asking about things that are influencing cardiac output, if I say a positive chronotropic agent is going to do what to cardiac output, it's going to increase it. But again, that is assuming everything else remains the same, which is going to be always unstated in the question. Unless I say something otherwise, then you need to kind of deal with that. But again, anything I change in here is usually going to be one factor. Well, how does this influence it? Assuming everything else remains the same. So factors that influence cardiac output. Increased preload, more into the heart means more out of the heart, which means more cardiac output. Like I said, very simply, more into the heart means more out of the heart. Increased back pressure against the heart, increased resistance on the exit of the heart is going to decrease cardiac output. We know anything that increases contractility is going to increase cardiac output. Obviously, the opposite on all these things is true. Heart rate, increased heart rate, assuming stroke volume remains the same, is going to increase cardiac output. Obviously, if there was differing directions on this one, you could have a change. You'd actually have to do the math. Mainly what we see though is generally with increasing heart rates, we usually also see increasing stroke volume. So generally heart rate is going to increase this, but again, I'm not probably going to give you something where it says stroke volume went up this much, heart rate went down this much, what was the effect on cardiac output. But again, you need to understand that all the things that influence cardiac output, because when we get to the next chapter here, we're going to start talking about blood pressure. And again, one of the quickest influencers of blood pressure is cardiac output. Increased cardiac output, assuming everything else remains the same, means increased blood pressure. Decreased cardiac output means decreased blood pressure. Therefore, anything we've talked about on this also is a regulator of blood pressure. Increased preload increases blood pressure, all things remain the same. Increased contractility increases blood pressure. Increased stroke volume increases blood pressure. These are all things that we'll see in the next chapter. And again, this kind of ties it all together here. A nice little one that's showing all this. So the positive and negative chronotropic agents and how they can influence in either to increase or decrease heart rate. The venous return directly related to stroke volume. Afterload inversely related to stroke volume. And we can see the inotropic agents can be positive or negative. But really the combination of that stroke volume times the heart rate is going to be what is our cardiac output. So again, just making sure you understand this. Again, not the simplest thing to measure in real life, because we can't just have a little cup here and say, oh, it pumped out more. There's no easy way to measure it, but this is a very good theoretical way to look at factors that influence the heart and influence the output of the heart and therefore influence blood pressure. So what this does is it really finishes up what we're going to be doing with the heart. Again, this will be, if I remember correctly, what is going to be kind of our endpoint of test 2. The thing to realize is a lot of this cardiac output we're talking about on the end of this one, this is also going to be fair game on those blood vessels tests, because we are going to be talking about blood pressure regulation, and anything with cardiac output is part of blood pressure regulation. So that is it for the heart. We'll see you next time when we start dealing with blood vessels.